Yeah, thanks for everybody for coming today. And this is Dr. Liam Sullivan. Liam and I have been friends for years. Our wives used to work together at Vaccinated Institute. And so Liam's an infectious disease doctor at Spectrum Health and here today to talk a little bit about COVID vaccination. I'm sure you're willing to answer any other questions we have related to the pandemic too. So thanks for coming and welcome, Liam.
Thank you.
Yeah.
Can you guys hear me? Can everybody hear me okay? So, like Tim said, I work right across the street over there for Spectrum Health. I've been there since 2012. I did my fellowship training at Cleveland Clinic, and I did my residency training at Metro Health in town here. So, I'm very familiar with the Grand Rapids area. I've been here a while, and great place to live and work. So I'm going to talk to you about, the majority of what I'm going to talk about up here will be about vaccines. As a caveat, I only have 15 slides because I've realized people probably have more questions, and I'm willing to answer any questions about it. As you've probably seen with this pandemic, the information changes fast and furious. I'm giving you snippets of some very recent stuff. And even today, this morning, I saw 3 more studies came out on vaccines. So it's really hard to keep up with all of this. I remember in med school, it reminds me of med school, my first day in med school, they're telling you that the information you get is like, it's gonna come at you like drinking water out of a fire hydrant. Well, the COVID-19 pandemic for medicine has been definitely equivalent to that, if not even worse than that. So this is just, like I said, just snippets, to kind of just bring you an update on some of the more recent stuff and some more recent studies that have been released. But like I said, several more got released today. Okay. And this will be interactive too. I mean, don't feel, no questions are dumb ones. The only dumb ones are when you don't ask, and you can interrupt me, et cetera. I'm not that formal. I'm very informal about this. So here, this is a map from the New York Times. If any of you have looked at the New York Times, the New York Times probably has one of the best sections on the COVID pandemic throughout all of this for lots of various information. So if you ever want to see case counts, et cetera, the New York Times is a really good place to look. This is a map. This is from a few days ago. It's probably not much different today, I would imagine. This just gives you an idea where the hot spots in the country are. And this is just looking at total case numbers per state or regions in the country. And you can see the darker the red is, the more cases they are having. So as you can see, the area in West Virginia, Kentucky, Tennessee are pretty big hot spots in the United States right now, as is some areas over in the Pacific Northwest, and continues to be in the South and in Texas. And Alaska's actually lighting up a little bit more as well. Yeah?
Just a quick question. Are those case numbers per capita?
Yeah, they are.
Okay.
They're case numbers.
Because I was looking at Alaska.
No, you're right. Yep, they're case numbers per capita. Good question. And they are not hospitalizations. Okay, mind you, so the two of them are a little obviously very different, and one would argue that very legitimately the hospitalizations are really the major metric we should pay attention to. And in medicine, that's the biggest one we're worried about is hospitalizations. But I will tell you that this correlates reasonably well with high hospitalizations across the country too. The more case numbers you have, the more hospitalizations you have, and there's several states that are in really bad, dire straits right now. Idaho, if you've probably seen recently, has declared a state emergency with case numbers so bad that they've had to go to somewhat of a rationing of care in Idaho. I don't know that it's come to that quite in some other states yet, but to say that healthcare systems are stressed across the country would be an understatement right now, and that includes Spectrum Health and St. Mary's and Metro in Grand Rapids here. We're all feeling the pinch right now for lots of reasons. Even though our COVID numbers aren't horrible, they're higher than what they had been, and plus the amount of people we're caring for otherwise is really high in the hospital, and all of us are at record census levels right now across our hospitals. And then we're having staffing problems, et cetera. So this is creating quite a problem right now, and it's a little uneasy for all of us because it's like flu season is coming, respiratory virus season. Last year, all those respiratory viruses disappeared, probably because of this thing right here. So anybody who argues with you that a mask doesn't work, well, what happened to flu last year? Flu was non-existent. So was RSV. And those two RSVs made a comeback. We're seeing a lot more RSV now. That's mostly a virus in kids. It does cause disease in adults. It's usually a mild respiratory illness in adults, but it can cause severe disease in kids. And they've seen a lot more of it in children over the last several months across the country and locally here as well. And we'll see with flu. Flu is a great unknown right now, because influenza's been with us for forever, it seems. And we have no idea what to expect from influenza this year. And then with COVID around concomitantly, it's like, we'll see what happens. Should be an interesting winter. And so here's the map of vaccination. Again, this is per capita, and this actually is percent vaccination, percent of residents that are fully vaccinated. The darker the green are, the more percentage of people 12 and over that are vaccinated. And as you can see, the northeast part of the country is probably the best part overall. Then there's scattered areas across the country that are also darker. And then there's some pretty light green areas across the country. And interestingly enough, a lot of those light green areas unfortunately correlate with the areas where we're having the most COVID hospitalizations and cases in the country. So in Michigan's kind of in the mid 50s to low 60s, if I'm not mistaken, overall. I think we're about 55-ish%, give or take a few, fully vaccinated 12 and over. And I think we're like close to 65% with at least one dose of a vaccine and over. So there's different parts of Michigan that are better than others. Like Leelanau County, for instance. Leelanau County has one of the best vaccination rates in the state. Leelanau County, last I looked, 12 and over, I believe it was 80%, hovering right around there. And then there's some other counties that are not so good. So, and if you look at that Leelanau County up there and Grand Traverse County are both very dark green. Hence the reason they're very well vaccinated counties in Michigan. Kent County's, I think, right around 65-ish, if I'm not mistaken. So variants. This is what makes the news all the time. Sometimes I wish the media would shut up about it a little bit, to be honest with you. So variants are definitely a concern. There's no doubt about it, but all viruses do this. They mutate as they go through population. I mean, I will say as an infectious disease doctor, this is somewhat fascinating to me, sickly as that might sound, but we're watching evolution in real time right now. And this is exactly what happens when you get a pathogen that has never, ever been introduced to a species before, and now all of a sudden it's finding a new home. And it is evolving with us as it burns through the population, and it is finding a way to propagate itself better and better and better. And that's what all pathogens do, be it virus, fungal, organism, bacteria, et cetera. They don't want to, ultimately, they really don't like to kill their host, because if they kill their host, they don't propagate themselves and they don't spread to another person usually. And SARS-CoV-2 is no different. It's looking for ways to propagate itself with the least amount of disruption to its host so it can spread itself from person to person to person. And the original virus, once people had antibody-mediated protection, after they kind of got through their illness, it was pretty good. Very good, and the vaccines protect very well against them, and so do some of our monoclonal antibody therapy. But then the variants started to appear. The biggest one, the first one that really started to make news worldwide was B.1.1.7, or Alpha as it is known now. And Alpha is not that much different than the original coronavirus, except Alpha had a better ability to spread because it had some mutations to its spike protein that enabled it to latch onto human cells a little bit better and replicate itself a little bit better, so it was more contagious. And I'll talk about the R0 of these various variants in a minute here. And so Alpha was the first big one that really made a splash in the news. Then along came Beta and Gamma. And if I'm not mistaken, Beta, I think, is the Brazilian one, P.1, and then Gamma is the South African one, B.1.351. I'm kind of glad they named the Greek thing now, because, oh my God, start trying to remember all these numbers. It makes your head start to swim. Okay? So Beta and Gamma kind of came along at the same time. They popped up in each region at very similar times. And the concern with Beta and Gamma was their reduced responsiveness to convalescent antibodies. And by that I mean antibodies in people who had previously been infected with the original strain of coronavirus. And so there was concern, okay, does that increase their risk for reinfection with these variants? And that was also a concern with vaccines. And that kind of bore out a little bit in the clinical trials. It particularly, the Pfizer and the Moderna trials, they did not have very many people infected with Beta and Gamma in their trials, so they really didn't present any data in their trials on them. But Johnson & Johnson did, because Johnson & Johnson did probably the most multinational study of all the companies. They had a pretty big chunk of people in South Africa and in Brazil during their study when these two variants were raging around those two countries. And so they did indeed show decreased ability to protect people from any infection, but Johnson & Johnson also maintained a very good effectiveness at keeping people out of the hospital, though. So that was the good news. The concern with always Beta and Gamma was, were they going to take off? They never have. Beta and Gamma are still around. They have never taken off. You know, they've really kind of, Brazil and South Africa is really the only two countries where they've really been the dominant virus. They are no longer dominant in either one of them. Delta has taken over, and I'm going to talk about Delta in a minute and why Delta is so special. But Beta and Gamma never took off in the United States or some other countries in the world. A couple of other South American countries, I think Beta was pretty high in its spread, but never in the United States, and that's because Gamma and Delta, or Gamma and Beta, do not have the same ability as Delta does. And what makes Delta so special is that Delta has acquired mutations to the spike protein, that's red, that enable it to really bind very, very well to the ACE receptors in the human respiratory tract. And this binding of Delta is much, much higher than any previous variant, including Alpha. And this has enabled Delta to replicate to exceedingly high levels within your respiratory tract. And if you think about it, the more virus that's replicating in your respiratory tract, the more virus that person is going to potentially spill out into the environment around them. That increases the potential to infect more people around them. And that's what's made Delta really, really a game changer. Delta completely changed the game of this whole pandemic because of this ability. And it's just pretty amazing how contagious this virus has become because of these mutations. And you know, it's interesting when you talk to virologists about this, really what's happening to the virus, it's becoming more fit. And by saying that more fit, the virus is evolving with us and it's developing ways to increase its ability to replicate. The virus itself really hasn't changed. It's just developing a better fitness and a better ability to interact with its host to maintain itself from person to person to person. And this, like I said, this is why it's become the dominant variant worldwide. I didn't have Alpha and Mu on here, or excuse me, Mu and Lambda. Mu and Lambda have gotten a lot of press recently. Mu and Lambda have been around for a little while, actually. They're not new. Lambda's been around in Peru for the last, I want to say 6 to 8 months, if I'm not mistaken. I think Lambda was discovered in late 2020, and Mu has been around for about 6 months or so. And you know, the concern with both of those is they both have mutations that can help evade vaccine and natural immunity. You know, they are less responsive to the neutralizing antibodies from vaccines and from natural infection. However, if you've noticed, Mu and Lambda have not taken off either, like Beta and Gamma. It's because Mu and Lambda don't have the same fitness advantages that Delta has. Most virologists seem to think that until a variant develops the same fitness advantage that Delta has, that it's probably not, that's what it's going to take for one to overcome Delta. That's why Delta overcame Gamma. Is this still working? Okay, good. That's why Delta overcame Alpha. And so for something to overcome Delta, it's going to have to mutate more. And what's very interesting about all this is this is what the press leaves out, because they don't really know what they're talking about, is, you know, I listen to a lot of podcasts on this, and I listen to some virologists. And so there was a very, very good study recently that was done. And if it's down here on the, no, it's not one of those, but it's, I have a link to it later on. These virologists took constructs they took the genome of SARS-CoV-2 and they made pseudovirus of it in a different virus. And they did all these genetic mutations to the spike protein. They intentionally mutated the spike in a different pseudovirus in the effort to see how many mutations it was going to take to make them fully resistant to our available vaccines and fully resistant to convalescent plasma from survivors. And they had convalescent plasma from people infected with Alpha, Delta, et cetera. And then they had plasma from people who were infected, plus getting 1 dose of an mRNA vaccine as well. And so they had all three of those. And it was very interesting. What they found is that the people who had COVID +1, so to speak, they had COVID plus 1 shot of an mRNA vaccine, the diversity and breadth of their antibody response was incredible, absolutely incredible. It's like the immune system was able to predict what the virus was going to do. And they could not find, they developed one variant that was able to completely evade those antibodies produced by those people, but it completely cost the virus fitness. The virus could not replicate. So it came at a cost to the virus. And what they found is that people who had, the COVID +1 was the best diversity and breadth of neutralizing antibodies that people, of the 3 groups of people that they compared, that was the best one. The vaccine one and the vaccine group and the natural infection group still stood up pretty well to most of the variants that they made. But they did find with increasing mutations, there is this increased ability of the virus to potentially escape either one of those. But it had a really hard time getting away from natural infection plus one mRNA shot. Not encouraging you to go out and get infected with COVID if you haven't been infected already. So, you know, but I think it just goes to show, I think the point of the study is, to me, it's two things. Number one, to show how powerful our immune system really is and how good it works. And then number two, that the virus, at some point in time, there becomes a fitness thing with the virus. And the virus can continue to mutate, and it probably will mutate some more, and it's very possible that another variant could spin out that's worse than Delta. But the question becomes, what does this do for other parts of the virus? And I think that's what we don't know. But at some point in time, it'll cost the virus. And that's probably why Mu and Lambda haven't been able to dominate, because they have not been able to develop the fitness advantages that Delta has, despite their ability to be a little bit more evasive to immune protection. Yeah.
Yeah, I think you might have answered my question, but is it known with coronaviruses that as they maybe increase their ability to become infectious, does that impact their ability to well, do you know, I guess I'll just stick with this. Does it impact the severity of disease they cause at all? Do you know, I mean, are those correlated at all?
You know, that's a very good question. So if you look at the other, there's 4 circulating yearly coronaviruses that cause the cold. And most people, some people it can cause a little bit more severe disease, but most people it's just a cold. And the question is, well, how did they evolve with us? And we don't really know, because they've been around for a long time, and you know, we don't have the techniques we have today. We didn't have years ago when these viruses evolved, and we probably really only found out about those coronaviruses within the last 30 to 40 years. But there's speculation that they probably evolved somewhat of a similar way. Viruses usually, you know, it's pathogens when they evolve, for them to evolve to the point where they cause more severe disease is not advantageous to them. And so most pathogens don't do that. They, if anything, the opposite is more likely to occur. What's going to happen with this one is a good question. You know, there's some suggestion, okay, like Delta, for instance. Does Delta cause more severe disease than Alpha or any other variant? And data suggests maybe, or is it just the fact that it's because of its ability to bind tighter and replicate higher? Is that just increasing the severity of disease just because of that ability of it right there, and infect more people? I think the jury is really out. Does it really cause a more severe disease? I think it's probably more a function of just its ability to be much more fit. I don't know that it causes any more severe disease. And most virologists and other experts don't seem to think that the evolution of the virus is going to be more severe disease. If anything, it's going to probably go the opposite way, because that's going to be more to the advantage of the virus to do that. You know, and that's why Ebola virus, I'll give you an example. Ebola burns itself out. Because Ebola, I mean, 80 to 90% of the people, Ebola and Marburg, its cousin, they kill 80 to 90% of the people they infect. So, you know, that big outbreak they had in West Africa several years ago with Ebola virus, even though it was horrible, don't get me wrong, and it killed thousands and thousands of people, eventually it would have burned itself out, because it gets to a point where it doesn't have anybody else to affect, because all of it's killed everybody. You know, so that is not to the pathogen's advantage to do that. But that is a really good question. It'll be interesting to see how this goes with this virus. So here's R naught. How many of you guys have heard of R naught? Okay. So R naught is what's called the replication coefficient of an infectious disease. Epidemiologists use this to describe, okay, when one person gets infected, on average, how many people around them do they infect? Hence R, and then a lowercase 0 on there, so R naught. And traditionally, so if you look at the 1918 flu, the Spanish flu pandemic, about 2 people, one person infected on average 2 people. The original COVID strain was about 3 people. Do anybody in here remember SARS-CoV-1, or the original SARS virus back in 2001, 2002? Yeah, it's kind of a cousin of our current coronavirus. They're reasonably closely related to one another. That average infected 4. HIV on average infects 4 people. And this doesn't account for method of spread, mind you. This just tells you how many people on average. So if you look at the original coronavirus, then we can come back. Chickenpox, about 10 people. Mumps, about 12. All the way to our poster child for contagiousness, measles, which is about 18. Measles is probably the most contagious infectious disease there is. what's made Delta so interesting is that the R0 went from between 2 and 3 to 8, to 7 to 8. Delta, in some studies, suggest Delta may be 8 to 9. Nevertheless, all the studies on Delta consistently show that the R0 is at least 2, potentially 3 times higher than the original COVID-19 strain. So that's why Delta's been a game changer. The amount of people it has infected is skyrocketed. So like I said, for a strain to have that to overtake Delta, it's going to probably have an R0 even higher than that. So that brings us to vaccines. So some of this is review for you guys, but here's the vaccines we currently use. There we have 2 mRNA vaccines by Pfizer and Moderna. One of them is 2 shots 21 days apart, the other one 28 days apart. Then there's adenovirus vector vaccines. There's actually 3 of them in use worldwide. In the United States, the only one we're using is Johnson & Johnson and Janssen. Janssen's the subsidiary company of Johnson & Johnson that really is the one that designed the vaccine. Then there's AstraZeneca, and right now, just back to J&J, right now it's 1 shot. They are doing a 2-shot trial right now. They have not released any data from their 2-shot trial yet. You probably did hear about the data that they released where they gave people who were in the 1-shot trial a booster shot 8 or 9 months later, and it increased the amount of antibodies. That's not from their 2-shot trial. Their 2-shot trial are 2 shots 56 days apart. I have not heard any data released from that one yet. They expect it any time now. And that's actually playing into the whole thing about should Johnson & Johnson people get a booster shot, which we'll talk about boosters at the end. Then there's AstraZeneca, 2 shots 21 days apart. AstraZeneca is not approved for use in the United States. They did do a clinical trial in the United States. Clinical trial showed reasonably good data, but for various reasons, AstraZeneca has not applied to FDA for approval, and I don't know if they ever will apply for approval in the US. And then there's the Gamaleya Institute, the Sputnik 5. This is actually, it's very interesting. This one uses both vectors from the J&J and the AstraZeneca. So the AstraZeneca and J&J are 2 different adenovirus vectors. The Gamaleya shot uses the 2 same vectors in a 2-shot series. They use one vector for the first dose and then another vector for the second shot. Again, 21 days apart. Kind of an interesting vaccine. There's not a lot of data on it, which is, it's kind of a mysterious one. There is some preliminary data suggests that it's pretty good, but we really don't know a whole lot about it. And then I'm just going to go down to the inactivated virus for a minute. Sinovac and Sinopharm, those are from China. They're inactivated whole SARS-CoV-2 viruses. Those are in use in other parts of the world, not in the United States, extensively throughout South America, Asia, et cetera. And then there's protein subunit vaccines. So Novavax and Sanofi are 2 companies that are developing protein subunit vaccines. They're 2 injections 21 days apart. Protein subunit is an old technology, as is inactivated virus. Influenza is inactivated virus. We use protein subunit in hepatitis B. I'm pretty sure Prevnar is a protein subunit. Shingles is a protein subunit vaccine. The new one, Shingrix, not Zostavax. Zostavax is live attenuated virus. I think HPV is a protein subunit vaccine. So protein subunit has been used a long time. And a lot of people would really like those 2 vaccines to be available. They probably will. The data looks really good on them. Sanofi's completing their study right now. They won't have results till later this year. Novavax has results, but they've been having, when you apply for FDA approval, there's this manufacturing issue you got to deal with. And like all the other vaccine companies, Novavax has had some manufacturing issues, so they're ironing those out before they go for FDA approval. Yeah.
This is working? Yeah. So you talked about the inactivated virus and protein subunit or used in the past vaccine technologies. This is a naive question, but is it true that some news would have you believe that there haven't been any vaccines that have been widely used before that used mRNA or the adenovirus vector technology?
Yeah, so the 2, Pfizer and the Moderna, are the first 2 mRNA vaccines ever widely used in humans. mRNA technology, they've been trying to get mRNA vaccines for 30 years. So the research into it is nothing new at all. And haven't you guys done research in a lab? I mean, I haven't. I'm just curious if anybody in here has. Okay? And I'm told that working with mRNA is actually really hard to do. It's a very unstable compound. And then when you put it in the human body, if it's not protected, our body has what are called RNases or enzymes that break down RNA like that immediately. So the messenger RNA in our cells, once it gets translated into its protein that it's coding for, it's broken down and gone within minutes, it's gone. And so that makes working with messenger RNA really, really hard. And that's been the key with mRNA vaccines. It's been instability and finding a way to deliver them effectively to where they need to get delivered to so your immune system can respond and make antibodies and T cells and all that stuff in response to it. So what the big breakthrough came in mRNA with the lipid nanoparticle. That was to protect it and deliver it to its target cells. So those are the first 2 vaccines ever used widely in humans. Adenovirus vectors have been used in humans. Ebola, okay, Johnson & Johnson and Janssen have an adenovirus vector vaccine for Ebola virus. They've used it in almost 180,000 people. They've had very good results with it in Ebola. There's actually a different there's another viral vector vaccine. I think it's made by Merck. It's vesicular stomatitis virus, VSV. That's another Ebola virus. So viral vectors have been used before in humans. They've been studied for a long time as well. And there's actually several other vaccines right now they're looking at. They're looking at a VSV SARS-CoV-2 vaccine. So that's always been an attractive target as well. And the virus and the vectors, just so you know, they're inactivated. All the DNA in that adenovirus vector, that the replication genes have been pulled out of the vector. The vector can't replicate. Okay, it's the vector's job. And basically, if you look at the adenovirus and the mRNA, the 2 of them work the same way, really very similarly. The way to think about it is the 2 of them are just delivering the coded message to the cells in a different way. The mRNA vaccines are using a lipid nanoparticle to deliver the code. The adenovirus vector is using a virus to help deliver the code to the cells. They're really, essentially after that, they're doing the exact same thing. They're delivering mRNA into a cell that our cell is using. That mRNA is translated by the enzymes in the cytoplasm of the cell into the spike protein. The spike protein gets expressed on the surface of the cell, doesn't circulate freely in the body as some people would have you believe. That's garbage. It does not circulate freely in the body. But SARS-CoV-2 does circulate freely in the body, by the way. So I just want to point that out there. I've seen that about spike proteins circulating in the body. That's nonsense. It gets expressed on the surface of a cell. It's usually in your lymphoid organs, whether it's in your lymph nodes, in your spleen, in your liver, because what happens is these special cells that uptake it get delivered to lymph nodes, and then it goes through your reticuloendothelial and your lymphatic system into your spleen and your liver primarily. And that's where a lot of this action is taking place, where the T cells and the B cells are seeing this and recognizing it and forming this intense immune response to it, making antibodies and memory T cells, memory B cells, et cetera. Okay? And so the adenovirus vector is basically doing the same thing, just a little bit different delivery mechanism. Okay? Any other questions on that? Yeah.
Yeah. So I've heard statements or information about so much protection, percentages for each of these vaccines.
Uh-huh.
Do you have a rank? Can you rank them as better than others?
Actually, we're going to talk about that in a minute. Yep, that's the next thing we'll talk about. That's a good question. So just so you know, so I think just to finish up on this point, Novavax, we'll probably have Novavax available late this year or early next year, most likely. I think there's a lot of people who are leery of the new technology with mRNA. Novavax will probably make some people feel a little bit better because it's tried and true technology. We've been using it for a long time. Works great. Don't have any problems with it. So I think I think Sanofi will be available too. And the great thing about both of those vaccines too, those are going to probably be the doctor's office vaccine. That is the one thing about mRNA vaccines is really hard. They don't have any preservatives in them. And the same with the J&J one. Once you stick a needle in that tube, in that vial, you got to use it or lose it. It's because there's nothing to preserve it in there. Whereas Novavax and Sanofi, if I'm not mistaken, have preservatives so you can puncture the vial over and over multiple times on several days. They were stored in the refrigerator, et cetera. So those vaccines, I think, are going to be, there's going to be a niche for those 2 vaccines. And I think they would be a welcome addition to the vaccine thing, because I think it would probably help some people feel a little bit better about some of the hesitancy. Because again, it's tried and true, and it's been used for years and years and years without any appreciable problems. And we're going to continue to use the protein subunit vaccines because they're really good vaccines. Yeah.
So the protein subunit, old technology, that's great. I've never heard of it before. So all of the public who claim to be worried about this new technology, mRNA, what's that science communication going to look like so that Novavax is able to be like, hey, this is something that has been used for this and this.
Yeah, so I think what you're going to hear them talk about is that it's made from the same technology that hepatitis B vaccine is made from, HPV, and a couple of other vaccines that we've been using for quite a while now. Hepatitis B has been in use for 30 years, HPV for about 10 years. I know HPV is not without controversies, but nevertheless, it's protein subunit. Shingrix has been around for about 6 or 7 years now. So I think that's what they'll talk about. They're going to relate it in that way, that these vaccines that we've been using for this long, this is very similar technology to that. It's almost identical technology to that. Okay? And then with the inactivated, the US does not have any inactivated virus vaccines, COVID vaccines. Flu is inactivated virus. Polio is inactivated virus. Used to be live attenuated, not anymore. Who in here had the sugar cube polio vaccine? Me. I had the sugar cube. Probably the best vaccine ever created. It has almost eliminated polio. There's only a couple small places in the world where polio still exists. Flu, there are live attenuated versions of influenza. Measles, mumps, and rubella is live attenuated still. We don't use live attenuated much anymore. That was an old way of making vaccines. They really aren't looking at doing that anymore. I don't think anybody's doing research with live attenuated SARS-CoV-2. I haven't seen anything. There are some pretty interesting things going on with the vaccines. There's an oral vaccine that's going to get ready to undergo clinical trials. And then there's a nasal vaccine that's going to get ready to undergo clinical trials. And I think, to me, the exciting thing about the nasal vaccine is that it has the potential to give you mucosal immunity in addition to systemic immunity. And mucosal immunity is very important, probably for preventing infection in the first place. And I'll talk about that in a little bit here. And that's sort of a messaging issue I think that we need to do a better job talking about. So vaccine efficacy. So here's the clinical trials. In the clinical trials, Moderna and Pfizer were essentially the same. Hardly any differences in the clinical trials. And then Janssen was a little bit below it. Although their trial was designed a little bit differently, they were looking more at prevention of severe hospitalizations and deaths. And then they did have a little bit lower efficacy against any infection. I will add that one of the things you got to remember when you compare them is that they had a lot of clinical trial participants in South Africa and Brazil. So that played into their overall efficacy. So they were dealing with beta and gamma variants a lot, whereas Moderna and Pfizer did not have any beta and gamma in their clinical trial. Okay, so just keep that in mind. And then Novavax, I think their preliminary data was out of a big trial in Britain. It was 90% effective, and that was mostly against alpha. That was the predominant strain there. One thing to remember about, there's a difference between efficacy and effectiveness, okay? Efficacy is in a clinical trial. Efficacy is under ideal circumstances, okay? Everybody's getting followed closely. Everybody's getting pestered to get their labs done. Everything is ideal. The groups are matched perfectly, et cetera, okay? That's not what happens in the real world. We all know that. In the real world, not everybody gets 2 shots. In the real world, somebody gets shot 6 weeks apart instead of 3 weeks apart, et cetera. All these other circumstances come into play in the real world. And then you have groups of people that weren't included in the clinical trials that are in the real world, immunocompromised people, pregnant people, breastfeeding people, et cetera. There's all these other groups of people that don't get included in there. And so effectiveness is always going to be different. You're probably going to have different numbers when you start using it in the real world. So which brings us to some effectiveness data. Did you have a question? Yeah.
So just it's one of the kind of complications in the real world that you mentioned that I've seen quite a bit is what would you say to someone who's like pregnant or thinking about becoming pregnant and worried about getting a vaccine, because it's hard to think about how you would see side effects on that sort of thing in a clinical trial just because of the time in the clinical trial.
Yeah, and the thing is, the clinical trials did not actively enroll pregnant patients, which, the American College of Obstetrics and Gynecology continues to harangue these companies over why they don't enroll pregnant people. And they're probably right, but in defense of them too, they're really worried about potential consequences of it. But there were some people who got pregnant in the clinical trials and they did not have any problems, but it's a small number of people, less than 10. So the CDC has a large registry of data on pregnant people through vSafe. They've been collecting it. And then there's been some other places that have done studies on pregnant people. And so far, at least as far as I've seen everything, that they have not detected any abnormalities above baseline, which you would see in the normal population in people who've been vaccinated with any of the vaccines. That has not been detected. It's still early, but ACOG and all the maternal fetal medicine, they all highly recommend pregnant people get vaccinated, because I'll tell you one thing we've noticed, if Delta's taught us anything, is that pregnant people get really sick, and a lot of them have died. Because pregnant people are slightly immunocompromised. They're at higher risk for SARS-CoV-2 complications. And that drives home the message that vaccine for pregnant women is probably very important. I think the most important thing for them is to have a good discussion with their OBGYN about it. But so far, there's been nothing so far that has suggested that any of the vaccines pose any undue risk to the mother or the fetus. There was this thing that when the RNA vaccines first came out, that the anti-spike antibodies cause infertility. Well, if that was the case, okay, we would have seen a rise in infertility among people who were naturally infected with SARS-CoV-2, and that has not been the case. So that whole thing has been completely dismissed and thrown out because it's false. Yeah, go ahead.
So a related question that I thought of when the mRNA vaccines were first rolling out, there was a lot of chatter and anecdotal evidence about their effect on birth control pills.
Mm-hmm.
And like I have friends of friends that, whether that's correlation or just coincidence, that was actually something that affected them. Have there been any follow-up studies about that? Because it was shortly after that the V-Safe check-in, I was starting to see questions that they had started to put in about if you're pregnant or planning to become pregnant. But those weren't there when I was first filling out those forms.
Yeah, I'll be honest, I have not heard about that. I am sure that there are some. I would be really surprised if ACOG and some other groups are not looking at that, because I'm sure that that's an active area. They want to make sure that there's no interference between the two of them. Scientifically, there's no plausible reason for it, but that doesn't mean it potentially couldn't be. So I'm sure that's something that's being looked at, but I haven't seen anything on it. That doesn't mean there isn't, though. I mean, the amount of information on this stuff is overwhelming at times. So, but that's a good question. I mean, it's, you want something that you want to make sure is okay as well. But there has been no effect on fertility. That's been pretty conclusively demonstrated, I think, at this point in time. And the pregnancy thing, I think data is mounting and mounting and mounting to show that they're safe in pregnancy. And at some point in time, I would venture to say down the road, FDA will probably give their full blessing for use in pregnant women. They haven't quite yet, just because they want to continue to gather data. But so far, so good. It looks pretty good. And there's been just so you know, none of the other all the other vaccines that we previously used, none of them have ever shown a problem in pregnancy. Hepatitis B, Prevnar, Shingrix, although we don't use Shingrix in pregnant women. But all those other vaccines, none of them have shown problems in pregnant women. Okay. So this study came out recently in the New England Journal of Medicine, speaking of vaccine safety. And I think, this is on the Pfizer vaccine. And to me, this slide sort of really is the take-home point from this study. What you're looking at here is the risk of certain potential side effects of vaccination versus COVID-19 infection. Okay? And COVID-19 infection is the stuff in yellow bars, and this is per 100,000 people infected. And then side effects potential vaccine side effects are in the blue bars. And if you look here, I think it's pretty dramatic when you look at acute kidney injury, arrhythmias, myocardial infarction, pulmonary embolism, and DVT, the risk that people who get actively infected with COVID-19 face compared to vaccine. There's no comparison in those side effects. And any one of those side effects can be a catastrophe for a patient and can kill them. And I think this drives home the point of how safe these vaccines really are. Yes, there's an increased risk for lymphadenopathy. That all vaccines show an increased risk for lymphadenopathy, and it has to do with the mechanism, how the immune system deals with the vaccine. So that is not an unexpected side effect. It's temporary and brief, and it goes away. I mean, you get a bug bite, you get lymphadenopathy from a bug bite. So, that's usually a very minor thing. But you don't see, people who get vaccinated don't get arrhythmias. People who get vaccinated don't get DVTs and PEs. Okay? People who get, yes, there is a little bit of a signal with myocarditis and pericarditis. I agree with that. And that's mostly been seen in young men, mostly under the age of 30. And it's being, examined very closely and watched very closely. The vast majority of the people who have gotten myocarditis or pericarditis, it's been mild and they have a complete resolution of their symptoms and they're fine. There have been a few cases where it's been a problem, and I think there's been a couple of deaths, if I'm not mistaken, that they think may be related to that. So, that is that, but those are exceedingly rare. So I think it's just very important to just, this really, like I said, drives home the point about how rare side effects really are. There is a little bit of a signal with herpes zoster in the vaccine. They've seen that with other vaccines too. This isn't the first vaccine that they've seen that with. And that may have to do with something with immune reactivation, because herpes zoster is a latent virus. It's chickenpox virus. Once you get chickenpox, you have that virus your whole life. You never get rid of it. It lays latent, dormant in your ganglion in your central nervous system, and then certain things later in life, whether it's immunosenescence, immune compromise, a severe illness or whatever, can cause reactivation of the virus. Something where there's either decreased immune surveillance or there's this wide range immune activation can lead to reactivation of the virus. And so that's probably what's playing the role. They don't quite understand that yet. It's not a huge thing, but there does seem to be a little bit of a signal there. So real world effectiveness. So this is a good study, another one done in New England Journal of Medicine. This was done by Public Health England. And they've done a phenomenal job with some of the studies they've done. Probably nobody's done better real world stuff than Public Health England. They collect data, they analyze it. It's really amazing. And their stuff's getting published in Lancet and New England Journal of Medicine. And if you're getting published in Lancet and New England Journal of Medicine, you're doing good science. I mean, I'm not saying everything, because you go back and look at the measles vaccine thing that got published in Lancet back in the late 90s, that was not good science. But that can happen with any journal potentially. But by and large, Lancet and New England Journal of Medicine, you're hitting prime time if you get published there. These guys have been doing really, really good work. Actually, you know what? I'm wrong. There's another study I'm gonna look at that's from them. This was done in the United States, actually. This is on the Pfizer vaccine in the United States. And they were looking at adults over the age of 50 between January and June, and they looked at over 41,000 hospital admissions. And really the take-home part is the part in the red bars there. And so they looked at fully vaccinated 2 doses. They actually compared Pfizer, Moderna, and Johnson & Johnson. And they're looking at the vaccine effectiveness at preventing hospitalization. And you can see Pfizer and Moderna are pretty neck and neck with one another, and Johnson & Johnson is a little bit behind. So real world data probably suggested that the mRNA vaccines are probably a little bit better. One thing I would say is that they're both 2 shots. The Johnson & Johnson is only 1 shot right now. It'll be really interesting to see when they come out with 2-shot data, what does that change their data at all? And nobody knows yet because they haven't released any of it yet. But I think suffice to say that for effectiveness at preventing hospitalization, they're holding up really, really well. They're doing very well. They're 90% effectiveness at keeping people out of the hospital for the mRNA, and just a little bit under 70% for the J&J vaccine. So I think they're doing, and a messaging thing I think that has probably been mismessaged from the start is, so the vaccines, when the clinical trials originally came out, we had this 95% efficacy against any infection. Everybody's like, oh man, holy cow. And it was sort of a double-edged sword. It was a double-edged sword on the one hand, and the good news is like, holy cow, these vaccines are above what we expected them to do. They're gonna be great. They're gonna prevent people from getting sick, yada, yada, yada. And then the other side of the coin is that if they don't perform that well, then everybody's gonna be saying, see, they don't work very well. They aren't doing their job, yada, yada. So they set the bar really, really high. And I think one of the mistakes that was made with the vaccines when they messaged them initially was to say, the object of these vaccines primarily in the beginning was not necessarily to prevent infection. It was to keep people out of the hospital and reduce the burden on the healthcare system by lowering the incidence of severe disease. And they are continuing to perform very, very well at that. They don't, because an injection, you're giving an injection and it goes into your systemic immune system, it's giving you systemic immunity. and it's creating immunity in the form of IgG antibodies, memory B, and memory T cells. There's another part of your immune system that's a little bit different. It's called your mucosal immune system. And your mucosal immune system is the part of your immune system that is exposed to the environment every single day. It's in your respiratory tract and your gastrointestinal tract and in your skin actually as well. Even though your skin's not your mucosa, your skin sort of has this special immune system as well. That's actually what, when we get a cut, a laceration and everything, that's kind of what prevents us from getting septic shock every time we get a cut. You know, so that because we have those immune cells that are sitting there defending us. And the mucosal immune system does the same thing. And the mucosal immune system's job is to prevent infection in the first place. And because there's special antibodies there called IgA antibodies, they're mucosal antibodies. That's really the only place you find IgA in your body, is in your gut and in your respiratory tract and your other mucosal surfaces. In a female, it would be in the vaginal tract, and a male also in your urethral tract, et cetera. So it's in all those mucosal areas where IgA is found. It really doesn't circulate in the blood at all, like IgG does. And polio vaccine, the reason polio vaccine is so good, the inactive, the live attenuated version, the sugar cube one, is that it mimicked natural infection with polio. You took it, polio is transmitted by the gastrointestinal tract. So you took this, you had this inactive, this live attenuated virus, it gave you mucosal immunity. And I like to compare it to a home invasion. So mucosal immunity is, when you get systemic immunity, the invaders can come into your home, and you got to try to get ready when they're in your home, and you got to try to kick them out of your house already. They're there already. You got to work to get them out. And it takes you a little while to get that response going to get them out. A mucosal immunity gives you, SARS-CoV-2 opens the door, and you're standing there with a shotgun and telling them, you're not coming into my house. That's really what it is, the difference between the two. Mucosal immunity is going to prevent infection. These vaccines weren't designed to do that. They are not designed to give us mucosal immunity. They're designed to give us systemic immunity, protect us from severe disease. You know, they are working on vaccines to give us mucosal, that hopefully will be able to give mucosal immunity. So those are down the line though right now. Natural infection, you do get mucosal immunity because you know you're getting the viruses invading through your respiratory tract. You're going to get mucosal immunity. So natural infection will give you that. But the vaccines don't. We do a better job at telling people that. That's why, you know, yes, you can still get infected, you know, but the vast majority of people who are getting infected, it's a very, very mild infection. It's a bad cold, and they don't have to be in the hospital. And the people who do get hospitalized, it's for various other reasons. It's because their immune system is weak, they're elderly, and they have immunosenescence, meaning their immune system just doesn't work as good as it used to, et cetera. So there's almost always underlying reasons why vaccinated people end up in the hospital. Yeah?
I had a question. It's a little unrelated to what you've been talking about, but about the rapid tests. Like if you're curious, you have COVID, you go down to CVS, they do a nasal swab in the car, sort of thing. I read somewhere, and I don't know if this is true, which is why I want to ask you, where if you presumed if you were sure you had COVID and you went and got one of those tests, it was like only 80% chance that test actually comes back positive if you have COVID. Is that true?
Well, so here's the deal with testing. So there's two different types of tests. There's antigen testing, which detects a part of the virus, okay? And antigen testing is only positive if you are actively infected because the whole virus is there, okay? And it's detecting a protein on the coat of the virus. PCR testing is detecting genetic material. Now, that can mean active infection under certain circumstances. In other circumstances, it might just be what we call RNA shedding. The virus is it's either dead virus. You can't tell the difference between dead and live virus. Antigen testing is only live virus. Antigen testing doesn't turn positive when people have, when you have dead virus. Okay? Antigen testing, the two of them have different sensitivities, and it depends on a couple of things. Number one, when you're swabbing people, and number two, the person who's performing the swab and how good of a sample they get. Okay? That has a lot to do with both of them, is operator performance. Okay? The best tests are the furthest back. You know, a good nasal pharyngeal swab should not be comfortable. Correct. And they're not really getting back there. Both tests operate best with a nasal pharyngeal swab, a good nasal pharyngeal swab. Some of them operate pretty good with what's called a mid-turbinate swab, where they go about halfway back there. Those aren't bad, and those are still not the most comfortable tests in the world either. I mean, you kind of come on here, kind of like this after, because I've had a couple of them done. It's like, oh, I do not like that. You know, and then you go further back and it's even worse. We tell people if you don't tickle their brain, you didn't do the nasopharyngeal swab right. So it has to be mid-turbinate or nasopharyngeal are the best specimens by far. Way too many of them, people just do the anterior nares. The anterior nares, your sensitivity goes way down for both of them because you're not getting a good sample. The virus doesn't really live in the anterior nares. Unless somebody's really early in the course of their illness and has a lot of symptoms, an anterior nares swab is probably going to be negative half the time, regardless if it's antigen or PCR test. Now, the problem with antigen testing and the rapid ones that they're doing, I think the rapid ones that they're doing at the pharmacies are antigen tests, I think. But they might be PCR too, I can't remember. Because there's rapid PCR tests available as well. The problem with, so let's just talk antigen. The one thing about antigen tests is that you got to be careful of is that if people are asymptomatic, they're only about 50% sensitive. That's the problem with an antigen test. If you are asymptomatic, the performance is not as good. If you are symptomatic, they're about 80 to 90%, depending on how the swab is done. If the swab is done right on a fully symptomatic person, the antigen tests are very, very good, okay? But it's the asymptomatic one. So it's very interesting. I saw this graph here one time in the New England Journal of Medicine, and the difference between using antigen and PCR testing is that, you know, when you look at people and their viral loads go like this, and you're doing testing at different time points, the best way to use antigen testing is to do several times because you're going to probably pick them up. If you do like 2 to 3 tests a week on somebody, you're probably going to hit them at one of these points where the viral load's really high, and you're going to get a positive antigen test. That's why like the professional sports leagues and the collegiate leagues, they did antigen testing. They did it multiple times a week, and so that's really when you're doing asymptomatic screening with that test, that's the best way to use it. Whereas the PCR test, you don't need to do it because the PCR test for symptomatic and asymptomatic people is generally really, really good. It's most of the time it's over 90% sensitive. Again, and it loses its sensitivity based on how the test is performed by the person. But most PCR tests are really good. The problem with the PCR test is it's too sensitive sometimes. You know, because we see people who are 3 weeks out of their illness, they're completely recovered, and you do a PCR test on them, they're positive. Probably picking up remnants of RNA. You know, so that's the problem with PCR testing. Does that answer your question? Yeah. Okay.
Quick, Liam, got a first question online. Somebody was asking to talk about the difference between natural infection protection, efficacy against reinfection.
Actually,
right?
I'm going to talk about that in a minute here. Yep,
Compared
that's
to
coming up.
vaccines.
That's a
Okay.
good question. Yeah, because there's a couple of good studies that have come out about that recently.
Okay, thanks.
Yep, we will get to that. So go back. So now vaccines and Delta. This has been a hot topic lately, and this is the Public Health England study I was talking about, New England Journal of Medicine. So this was done from October 2020 to May 2021, and you know they had 19,000 cases here, and majority of them were alpha, but towards the end of this, that's when Delta started to become predominant in England, and so they had a little over 4,000 Delta cases here. And they looked at vaccine efficacy, looking at Pfizer and the AstraZeneca vaccine. And as you can see here, if you look at the chart up here, it tells you after one dose, you know, neither one of them were that great. You know, only about 30% for the against Delta and about 48% against Alpha after one dose. But then you give the second dose, and overall vaccine efficacy was really, really good after 2 doses of either vaccine. And this is, you know, the graphs above are combined data from both the AstraZeneca and the Pfizer vaccine, the overall vaccine efficacy, and this is efficacy against hospitalization, okay? And then down here, they break it out by each individual vaccine. As you can see, against Delta, the Pfizer one's a little bit better than the AstraZeneca one against hospitalization. But I think the point of the studies is shows that 2 doses of either vaccine, even against Delta, offer very, very good protection against hospitalization. You know, public health, England's getting ready to do booster shots. We'll talk about the booster issue in a minute, but you know, suffice to say that it would not shock me if at some point in time the mRNA shots all become a 3-shot series, because there are some vaccines that we use that right now that are 3-shot series. Hep B is one of them. You get a shot at 1 month, 28 days, and then 6 months. And I think there's a couple of other vaccines that are like that, so it would not at all be that surprising. So it brings us to breakthrough infections. You know, this has been a hot topic as well. And the way the media talks about it is you would think that everybody's getting a breakthrough infection. okay? Yes, they are going up. I'm not gonna lie to you, they are going up. There's no doubt about it. And they're, part of the reason they're going up is we got more and more and more and more people vaccinated. So as you, by numbers alone, if you increase the number of vaccinated people, you're gonna get more breakthrough infections in vaccinated people. And then Delta's playing a role in this too. There's no doubt that Delta has an increased propensity to cause breakthrough infections in vaccinated people. That's, I think that is pretty much beyond argument. Overall though, that's still pretty rare. You know, you don't see, when you, especially when you start looking at them compared to unvaccinated people, the rate of infection in vaccinated versus unvaccinated, it's not even close. It's not even close, okay? And that's by unvaccinated and no natural immunity, by the way, okay? So they have no history of COVID infection, no vaccine, so they have no defenses against this virus. Their rate of infection is significantly higher than a vaccinated person's would be, okay? And all the vaccines are continuing to provide excellent protection against hospitalization. And then there's a CD study that just came out earlier this week that showed 86% in June and August. That's all predominant Delta. There are several other ones that came out today in the New England Journal of Medicine that say the same thing, that are providing really good protection against Delta, in hospitalization. So they're doing their job in keeping people out of the hospital by and large. Now, do people with vaccines get hospitalized? Sure they do, okay? No vaccine is perfect. You know, the human body is, you guys are all science teachers, correct? You know, and all of us are genetically different. And we all have differences in slight differences in our biology, and we're all gonna react to things differently. That's why, for instance, if you take two people with leukemia, giving them chemotherapy, one person might do great with it, the other one not so great. There's lots of different reasons for that. And it's the same thing with other medications. Some people do great with an ACE inhibitor for hypertension. Somebody else doesn't do great with an ACE inhibitor, and they need an ARB or they need a calcium channel blocker, et cetera, because of lots of these genetic polymorphisms, as we call it, and other environmental circumstances that come into play in our ability to react to medications. Vaccines are no different. You know, not everybody has the exact same response to vaccines. That being said, what we do know, and I know this is true at our hospital, the vast majority of people who are vaccinated and in the hospital, it's because either they're older, over the age of 75, they have significant medical comorbidities, you know, heart disease, kidney disease, leukemias, lymphomas, et cetera, you know, diabetes, you know, you take your pick on all the medical comorbidities they have. They usually have 4 or more medical comorbidities, or they're immunocompromised. And a lot of immunocompromised patients just don't have the ability to have as good a response to vaccination for any vaccination as a person with a fully competent immune system. And some immunocompromising conditions are worse than others. They're not all equal. I'll give you an example. I take care of a lot of patients with hematologic malignancies. I see complications from infection and lots of lymphoma, leukemia, multiple myeloma, and bone marrow transplant patients. And it's very interesting just what you see with the vaccines in them. And there's actually a study that just came out that talked about this issue. People with lymphoma, multiple myeloma, actually do worse than leukemia patients. And it's because of the pathology of their disease. People with lymphoma, multiple myeloma have a hard time making antibodies, and a lot of their chemotherapy they get impairs their ability to make antibodies. So when you give them a vaccine, they just have a really poor response to at least to the antibody part of the vaccine. That doesn't tell you about the T cell response of the vaccine, okay? And it's interesting, when I've seen these patients get admitted to the hospital, they're persistently positive for COVID, and they're still having some symptoms, but they're not really ill. They're just kind of having fevers, and they just achy, and they just feel like garbage, and they can't get rid of the virus. But they aren't on the vent. They aren't needing oxygen, generally speaking. And overall, they aren't having any other complications. That's probably because the vaccine's giving them T-cell mediated immunity, which is protecting them from severe disease. But their body can't completely clear the virus because their B-cell mediated or antibody mediated immunity is impaired from their disease or from the chemotherapy that they've received. Leukemia patients, it's interesting, AML, acute myeloid leukemia, which affects the white blood cells in our body that are called neutrophils, you don't see this. They tend to do reasonably well with COVID if they're vaccinated. They have a pretty good response to the vaccine because the vaccine is not their underlying disease is not really playing around with their B or T cell mediated immune system, and they tend to do better. And so it's kind of interesting. Then there's other people who are on rituximab, methotrexate, other tacrolimus, mycophenolate mofetil, solid organ transplant patients, they all have a decreased response to vaccination because of the medications that they're receiving. So that's why people who are vaccinated end up in the hospital. And then it's very interesting when you look at in our hospital and nationally, about 40 to 50% of the people who are vaccinated and hospitalized, it's an incidental discovery at hospitalization because they're there for trauma, they're there for, they have an bleeding ulcer or whatever, any name, you name it, they're there. We screen everybody for COVID right now because it's so prevalent in the community. We want to make sure that we're not infecting our workers and other patients in the hospital, so everybody gets a COVID screen when they come in. And we incidentally discovered they're completely asymptomatic from a COVID standpoint, and person's there with a busted leg and they're COVID positive. It's like, huh. And they're vaccinated, but they're like, yeah, I feel fine, I don't know anything. So about 40 to 50%. So when you look at those stats nationally, and that's borne out true across the country, keep that in mind when you see all these vaccinated patients who are hospitalized. A lot of them are incidental pickups. And then the ones who are really there that are sick for a reason. The 35-year-old healthy person with a good immune system that's vaccinated doesn't end up in the hospital. They're got a bad cold at home or no symptoms at all. So which brings us to vaccines and transmission. So again, Public Health England did this study on looking at, this is when alpha was predominant, and they looked at patients, 93% of the patients had 1 dose of vaccine here. And so they looked at household contacts. How often did household contacts of these healthcare workers become between the vaccinated and the unvaccinated, what was the rate of infection in their household contacts? And what they found is that the people who had at least 1 dose of vaccine, there was a lower rate of infection in their household contacts compared to people who did not have any vaccine. So what that suggests, and I want a keyword there being suggests, is that the vaccines probably lower transmission. Okay, but now I go back to that whole thing about systemic and mucosal immunity. When you get a viral variant that is really, really efficient at reproducing in the respiratory tract like Delta is, when you don't have that good mucosal immunity, maybe it's not so good at preventing transmission. And that's why this study was done in Singapore. Okay? And if you look here, this is kind of confusing, I know, but the green are vaccinated people. These are PCRs on vaccinated people, and these are unvaccinated people. And what it's showing you is what's called a cycle threshold value, or CT. It's a surrogate marker for infectious virus. So when you do a PCR on somebody in the lab, has anybody ever done PCRs in the lab before in here? You probably know what cycle thresholds are. That when you're looking for your target, the higher the number of cycles you got to go through, the more rare the target is. So a high cycle threshold means there's not much there. A low cycle threshold means it's abundant, and you don't have to do it that often to find what you're looking for. And in this case, SARS-CoV-2 RNA. And so generally speaking, when they look at cycle thresholds, a cycle threshold under 25 is considered pretty high, indicative of quite a bit of RNA there. Over 25 to 30 is like, kind of in the middle. And over 30, most of the time it's considered you're really having to look for it. Now, I want to caution that is that, one, it's variable from lab to lab to lab, okay? And number two is that this is a surrogate marker. It's only picking up RNA. It's not picking up live virus. It can be live, dead, or partially assembled virus, okay? So it's very important to remember that. This is a surrogate marker. The only way to look at this is you got to do live viral culture if you want to know, truly. And there are some studies going on looking at transmission in live viral culture, and those are extremely labor intensive to do. If anybody who's done, and I haven't done this research, but I know a couple people have, they tell you growing viruses in a lab is not like growing bacteria on a petri dish. Completely different story between the two of them. So, that's why we don't do live viral culture in hospitals anymore for diagnostic studies, because it's impractical. It's just really difficult to do. But they're doing them in research studies, and I'm sure we'll hear more about transmission about that. The point of this, though, is what they showed is that, so in the beginning, right here, both the people infected, vaccinated, and the infected, unvaccinated had pretty equivalent cycle threshold values in the beginning. But then you look several days into their illness, now they start to separate from each other pretty rapidly, and you see a much steeper and faster decline amongst the vaccinated people than you do amongst the unvaccinated people. And so what that is saying is that what that seems to indicate is that as time goes on, the unvaccinated people are probably shedding less and less virus a lot quicker. because their immune system is kicking in and getting rid of the virus and getting the infection under control a lot faster than an unvaccinated, previously uninfected person is, because they're completely naive, and it's going to take their immune system 7 to 8 days to really start doing something, whereas the vaccinated person, within 24 to 48 hours, it really starts to kick in. And most people, from day one here, most people are asymptomatic at that point, because most people shed virus for 24 to 48 hours before they develop symptoms. So as you can see there, if you go out to day 4-ish, the separation starts. So, these are early studies. They're going to see a lot more about this, but I think the trend seems to be that, yes, with Delta, vaccinated people are capable of transmitting it. Again, I go back to the mucosal immunity thing. It's not surprising, but what you're going to see is that their level of contagiousness is going to go down a lot faster than the naive, unvaccinated person does. So more to come on this, but that's kind of it's encouraging to see that, yes, the vaccines are doing their job. They are slowing, they will slow transmission down. Now, the Provincetown study in the CDC that got everybody excited, one of the problems with it is, anybody ever been to Provincetown? Hey, I've never been there, but I've seen some documentaries on it. So Provincetown's on Cape Cod, and in the summertime, it's party central, okay? And everybody is really crowded there, and they're close together, indoors, outdoors, et cetera. And apparently at the time the CDC was looking at this outbreak, it was kind of crummy weather, so it was driving a lot of people indoors. Super spreader events, pretty much. The point of the Provincetown is to show that, yes, vaccine people can transmit the virus, but at the same time, you got to kind of is that whole incident indicative of what is always happening with vaccinated people? And probably not. That's, and I think time will show that, that's a different circumstance, and that, yes, the vaccinated people can transmit it, but it's probably a lot less so than the unvaccinated, naive people. Which brings us to natural immunity and infection. So this is a hot topic of debate, and a Cleveland Clinic study that was done, it's a preprint study, it's number 1 on the bottom there. I thought I heard that it's accepted for publication. I just don't know what journal. And I actually know the authors. I did my training at Cleveland Clinic, and I know the guys who did this study, and they're very, very smart people, probably some of the smartest people I've ever met. And they're very, very good researchers. And I have no doubt that they did this study very well. They did this study at a time when vaccines were scarce, and they wanted to see, okay, in a time of vaccine scarcity, should we, when we were prioritizing vaccines for people in the population, should we vaccinate infected healthcare workers versus saving the vaccines for people that have not been infected, have no immunity, and give it to them? And what their study showed us was that there was really no benefit to vaccinating healthcare workers who had been previously infected. And that the point of the study was to show that we should save the vaccine for the uninfected, immune-naive population because they're scarce. Okay? And then what about Delta? Everybody says, well, what is Delta going to show? So an Israeli preprint study that, again, is preprint. And I want to emphasize the preprint thing is pretty important, because preprint means it's not been peer-reviewed yet. And anybody who's looked at journal articles know that the peer review process is really intense, and there's a hell of a lot of stuff that gets thrown out in preprint and peer review. But unfortunately, we live in the era of preprint scientific medicine right now, and we got to deal with it. And we're left kind of having to address them. Nevertheless, Israel's done a lot of really good work, like Public Health England. In this Israeli study, I would not be surprised if it gets published as well. What it has shown, too, is it suggests that natural infection may be more protective than vaccination against Delta. I mean, the numbers in it are pretty impressive. One, it's a retrospective study, so keep that in mind. And when you start really looking at the weeds and looking at the data in there, you see that a lot of the vaccinated people who got infected in the study were elderly people, had been vaccinated several months ago, et cetera. So there's some caveats to it. But nevertheless, I think it is intriguing, and it probably does suggest that natural immunity is pretty darn good against this virus. That being said, this is the study I was referring to earlier. This is number 3 down here, is that studies, however, suggest that when you've had a history of COVID-19 infection and you get 1 dose of vaccine, the diversity and breadth of the antibodies your body makes is phenomenal. It's absolutely incredible what it does. And that's why we encourage people, yes, you have a history of COVID-19 infection, get at least 1 dose of vaccine. And I'll tell people this, if you survived COVID, the vaccine, you're going to survive the 1 dose of the vaccine just fine. Okay? COVID, as I pointed out before, has much higher potential to cause significant problems than the vaccines do. And and the immunity you generate from this is remarkable right now. And I think this is just why I would just encourage you, please consider it, because it's really going to protect you, give you a very, very high level of protection, not only against the current variants, but probably against variants that are going to come out in the future. And that's what this study showed, is that these people have really this incredible depth and breadth of antibodies, because our immune system is absolutely amazing. We haven't been around for as long as we've been bombarded by all these pathogens without an immune system that is amazing at protecting us. And I'll tell you, some of the infections I see in people, I wonder how the hell I'm up walking every day because of what these pathogens can do to people. And it truly speaks to how amazingly powerful our immune system is. And it's obviously learned to do a lot over time. But it's also what amazes me, and this is part of my passion in infectious diseases, how Mother Nature, on the other hand, keeps throwing curveballs and sliders and fastballs and sinkers at us. And we keep having to learn how to hit over and over and over again. And so it's a pretty amazing evolutionary tug of war going on between us and the microbial world. And it's never going to go away. So the bottom line, like I said, COVID plus 1, history of COVID plus 1 mRNA vaccine, or any vaccine for that matter, is probably going to give you the best immunity at this time. But as with all things COVID, could this change? Sure it could. It might. It's possible. I don't know. We'll see. And lastly, booster shots. Hot topic. FDA met about it today. I haven't seen the results of their discussion. They did. I suspected they were going to reject it. And if you read any of the news, ACIP, the Advisory Council on Immunization Practices, which are all vaccine experts, and the FDA Vaccine Committee were dead set against this. They did not think that there was good data to support widespread booster shots for the general public. And this is why this just came out in Lancet a couple of days ago. And what they're showing here is vaccine efficacy against severe disease on the y-axis and against any infection on the x-axis, and they're breaking it down by variant, early and later, vector vaccine, and then these were the first, the A was the clinical trials. And so if you look on here, the astounding thing is the high level of protection against severe disease that is consistent on all 4 graphs. And that's why these authors felt that we're going to get more bang for our buck vaccinating the immunologically naive people around the world than we are to start giving booster shots to people who don't need a booster shot yet. Okay? Now, is it possible we're going to need one in the future? Sure it is. I think there is some people who think that ideally this vaccine series, probably 3 shots might be the best. They're looking at that. And the reason there's some thinking along those lines is that it's when in England, what they did is when they look at, because they delayed their second shot by 12 weeks no matter which vaccine you got, and it seems to have worked a little bit better. And they think the theory is that the first dose primes the immune system, gets it all excited, but then you give the immune system a chance to rest and sort of take stock of what it just saw and it's going on, and then hit it again, but at a later time, so that it has fully processed everything that it has seen, and it may give you a better response down the road. So that's kind of the thinking. But the reason that the clinical trials were done as they did is we had no treatment for COVID. I don't care. Ivermectin doesn't work. Hydroxychloroquine doesn't work. Remdesivir's not that great. Dexamethasone just does have some of a mortality benefit, but if you're on the vent already, that's not where you want to be. So we have nothing to treat severely ill patients. The best thing we had to do is keep them out of the hospital. And so when they just did the clinical trials, they had to try to expedite them, design them in such a way so that they didn't have time to do one shot at 28, one shot at 0, 28, and 6 months. Okay, let's just do it at day 1, and then 21 or 28, depending on which vaccine, and let's do the trial and let's see how it works. And I'm not saying they were reckless in doing it. They weren't reckless at all. They were very, very well conducted clinical trials, but the point I'm trying to make is the state of the pandemic didn't allow them to do this one where they could do the third shot 6 months later to really see. And I think that the future look at the vaccines is going to look at that. And it wouldn't surprise me if it might turn out to be the case that separating them more might be the better way to go. We'll see. You know, that remains to be seen. It's possible. Yeah.
Thanks. This is really informative. Is there any risk of continuously giving boosters of these mRNA vaccines?
Like, are you saying the risk to the people who get them?
Yeah, I mean we're using a lipid-based packet. I don't know if mRNA being introduced into the bloodstream or anything. If we keep seeing successive boosters, what are the concerns or thoughts around that?
Well, I think that the only concern right now with the booster shot is because they didn't do trials on it, they don't know the potential side effects of the third shot. So that's one legitimate concern, because the clinical trials all looked at 2 shots. Is it going to be a problem? Probably not. Because the mRNA, so the RNA itself, if the RNA gets exposed into the bloodstream, it's going to get busted down really quickly. RNA will not survive in your blood unprotected. And then, and most of what happens is when you get the injection, it goes into a muscle, and then actually most of the lipid particles get uptaken into your lymphatic system and delivered to the lymph nodes. Some of them sure make it into the systemic circulation, and they're going to make it into the venous circulation and probably get pumped through the liver and the spleen, or go through the lungs. And you also have immune tissue and everything, and immune centers in your lungs as well. And I know there's been some people who've had this concern about the lipid particles and what potential side effects the lipid particles could have. I will tell you this: even though the lipid particles are different, we use liposomal medications in medicine all the time, with pegylated interferon, pegylated chemotherapy agents, et cetera. There's lots of different use that we've been doing this. They're a little bit different than the lipid particles used, the nanoparticles here, granted, but it's the same principle. I use one all the time called liposomal amphotericin B. It's an antifungal agent. And the lipid thing probably protects people from some untoward side effects than causes side effects in and of itself. Those risks are somewhat theoretical. I'm not here to dismiss them and saying that they shouldn't be thought about, because they should be. It's a foreign substance going in the body. And to me, that just brings it back to the point about vaccines is that I want to emphasize the point. Every single thing we put into our body, whether it's Tylenol, Motrin, a piece of corn, a steak, candy, a cookie, etc., it's all foreign. All of it is. And every human being is different. And there is always the potential for a side effect when you take something that the human body looks at as, you don't belong in my body, okay? And it's foreign, there's always the potential something could happen. And these vaccines, there has been no vaccine in the history of medicine that has been under the microscope and has gotten the scrutiny that these vaccines have gotten. And when you look at how many hundreds of millions of people that have been given the vaccines worldwide, of course there's going to be some side effects. That's beyond doubt. No clinical trial can figure all that out. The biggest clinical trials, if you look at in medicine, are 40 to 50,000 people is the biggest you're ever going to get, because the logistics, the cost, the manpower to run a trial that big is really, really difficult to do. Okay, and whenever you take something that looks great in a clinical trial and you start rolling it out to millions and millions and millions of people, there's something possibly can happen. And there's no way that a clinical trial is going to predict all of that stuff. But I think by and large, when you look at, other than a few signals here and there, the vaccines have stood up pretty darn well, especially when you compare them to the other ones we've been using for 40 years. Their rates of side effects are no worse, generally speaking, than, there's a couple of things, the myocarditis, pericarditis in certain groups of people, and then the thrombosis with thrombocytopenia in the Johnson & Johnson vaccine, which they've identified what group of people shouldn't get it. Those people aren't getting it. We don't see those cases anymore. So the safety monitoring system has been working pretty darn well, I would say, with these vaccines. And I think if you were to take 500 million people and give them Motrin, I guarantee you're going to have a hell of a lot more problems in people. The rate of side effects is going to be a heck of a lot higher with Motrin than it will be with these vaccines. So I really want to emphasize to people, it's a foreign thing. Of course, things can happen, but by and large, they've been very, very safe and worked really well so far. I think they've exceeded our expectations. I think our messaging on that just needs to improve and not get people thinking the thing. They keep us out of the hospital. That's the key right now. Hopefully down the road we find one that prevents infection altogether. Does that answer your question? I know I got off topic there a little bit, but that's a legitimate question about the lipid thing. I don't disagree that that's, but that's something that, people have been looking at and thinking about theoretically a little bit. But, the third shot, and I think that's one of the reasons too, FDA and ACIP are kind of like, let's study that a little bit more. Let's make sure that there's nothing, it's not going to show anything. And so I think that's probably one of their reasons to be very hesitant of it as well. And I think that's prudent on their part. And I'm glad to hear FDA did reject that. For immune-compromised people, I think that, like solid organ transplant patients, it's pretty crystal clear they need that third shot. They need it because they don't get a good immune response or two. Yeah, other questions?
One quick question that came in from online. I know this is probably a hard one to answer. Do you have any personal thoughts on the origin of the virus? You can thank Tim Perriard for that question.
I've listened to a lot of podcasts from some people who know a heck of a lot more about that than I do, and from some people who've done international studies on this stuff. And the one thing I'm going to say is it doesn't really matter right now because the virus is here, and we got to deal with it, and we got to figure out how to deal with it. Okay? Would it be great to know where it came from? Sure, it would. And I think it's important for us to keep an open mind about where it came from. Could it have been a lab leak? It's possible. I think it's impossible to completely dismiss that theory. But I don't know that we're ever going to find out. And I think I heard an expert say this really well. I really like this, because he thinks most people, really good people, think it's probably a naturally occurring event. But some people do keep their mind open to a potential leak, and they make the point that, okay, do you think if the similar thing happened in the United States, we're going to let everybody else waltz in here and we're going to be honest with the world? Really? The United States no country in the world is going to say, hey, we had this big lab leak and we released this virus. They're not going to come clean. So sure, it could have happened. It's hard to say. It'd be nice to know for sure because, if it did happen, we should have safeguards in place to prevent it from happening again. And if we do find out that that's how it happened, that's a good thing. But at the same time, I'm going to tell you right now, the more interactions we have with other species and the way things go, if you listen to Lori Garrett's a really she writes a lot about infectious diseases. She talks about the wild animal market in Southeast Asia and that there's this black market for these animals and where the conditions they're in with humans around them and everything. You can very easily hear, if you listen to her talk, you kind of think, yeah, it could very easily jump from one species into another. So I think either one of them it's probably more plausible that it came from Mother Nature itself. And this won't be the last time it happens. And it's not the first time if that's how it came about. So, but I honestly don't know, and I don't have a strong feeling that it was one thing. And for my mind, I honestly don't care. Because it's here, we got to deal with it.
Maybe related to that, if I can ask another question.
Yeah.
What do you think, I know this is probably a little bit speculative, the future of the pandemic, 5, 10 years from now? Are we talking about seasonal shots with new variants?
Yeah, that's the million-dollar question. And as lots of people like to say, the COVID crystal ball is very muddy. I think if anything, what this virus has shown us is that, everybody has a prediction, but, most of them are inaccurate. People predicted various things throughout this whole pandemic, and very few of them have come true. People say the virus is going to become seasonal. It hasn't become seasonal, not yet. Maybe it will, but not yet. Some people say, we got herd immunity in the United States. Right now, we don't have herd immunity in the United States. So I don't think we're going to, my hunch is that we won't have yearly booster shots, okay? Just based on a lot of the immunology I've read and stuff that virologists have said, I don't think that that's going to be necessary. Do I think we might need a shot every now and again? Possibly. That would not surprise me. I do think at some point in time this virus will settle down to become the 5th seasonal coronavirus. That It's not going anywhere. It'll remain in circulation in the population. It will cause severe disease in some people. Most people, though, will have some degree of immunity to it, whether it's via natural infection, vaccination, or combination thereof. And they will have a mild upper respiratory tract infection, and it'll become like influenza. It'll probably be more like influenza than its cousin coronaviruses, because influenza has more of a propensity to potentially cause severe disease and lower respiratory tract disease than other respiratory viruses do, so it's probably more likely to become like flu. But flu viruses and coronaviruses are very different genetically. Influenza viruses are horrible quality control when they replicate. And plus, they do a lot of this mixing and matching in hosts where they start swap and spit with one another. And that's why you get antigenic drift and shift with flu viruses that you don't see with other viruses, because they're very promiscuous with each other, for lack of a better way of putting it. That's kind of what they are. Whereas coronaviruses don't have that. Coronaviruses actually have reasonably good quality control when they replicate. So I don't think you'll see it become like influenza. But some pretty prominent vaccinologists seem to think that maybe one more booster shot at some point in the future that's been tweaked or altered in some way, shape, or form, and that might be it for a long time for most people. But we'll see. We don't know. But I don't think it'll become seasonal. I honestly don't think that that's going to happen. And most experts don't think that'll happen. A seasonal shot, that is. I mean, is it possible? Sure, but not likely. Other questions? Oh, you're welcome. You're welcome. My pleasure.
Everybody online says thanks too.
Oh, great. My pleasure. Thanks for inviting me. I really appreciate the opportunity to come talk to you. I would do it any time, so I thank you guys too. Oh, let's see here.